Thanks very much for the invitation. I'm, as Steve already said, very happy to be here and enjoying the nice surrounding and food in Kraków. So I'm going to talk about Erasmus Plus funded project iCoViP, which we implemented in a European, as a European project, and it's about creating a collection of virtual patients for the training of clinical reasoning. So a disclosure, I'm partly funded by this Erasmus Plus project and another one, and I'm an employee at the University of Augsburg. So first of all, I would like to touch upon the project aims we have for iCoViP. As the name already says, it's the first aim is developing a high quality, diverse, and multilingual collection of virtual patients. We aim for creating 200 for medical students and young professionals for the training of clinical reasoning. But as a side effect, as we have multiple languages, we can also use those virtual patients to support students when they want to go to another country. The languages we have is German, English, Polish, Spanish, Portuguese, French, and as we have a new project also coming along, we're translating a couple of cases into Ukrainian. The second aim we have is, in general, raising awareness about virtual patients, and maybe the most crucial point, as we heard this already in the morning session, is how can we integrate resources like virtual patients into the curriculum? So this is also a very important aspect of that project. So as I said, we are a partnership of from different countries. So we have partners from Paris, from Zaragoza, from Porto, of course here from Kraków, the Jagiellonian University, and we have two partners from Germany, from Munich and from Augsburg. And as I mentioned, we have a new smaller project that is funded by the German National Agency, where we can create also learning resources to support Ukrainian health educators in continuing their teaching with those virtual patients. Before I go more into the aspects of clinical reasoning, I would briefly like to explain what our project understands under the term virtual patients, because as other terms like clinical reasoning or other terms, it's a very vague term and there can be many different forms of virtual patients. So what we are creating are, in technology terms, quite simple virtual patients. The case starts with a patient presenting, so we are using text dialogues to let patients explain their key symptoms. Then there's a history taking, a physical exam. Then there are other exams depending on the symptoms the patient presents. Students are then asked to make a final diagnosis, and then there is some management workup and the prognosis of the patient. You can see a screenshot here on the screen. It's one of the screen cards of the system Casus we are using. So you see we have text elements. We can have questions like multiple choice or multimedia elements like images or videos. But what the clinical reasoning part is, and it's on the right-hand side, is a kind of a simplified concept mapping approach. So we ask students why they're working through the virtual patient to come up with the findings they had identified and prioritize them. We ask them to develop and document differential diagnosis, to suggest tests and examinations, what they want to do in order to rule out or confirm their differential diagnosis. And we ask them also to come up with treatment options for the patient. What we also ask students is to connect these elements with each other. So if they have a finding, they should think about what does this finding change for my differential diagnosis? So in this case, you see a red connection between fever and asthma. So the original hypothesis was that this patient could have asthma, but then the patient turned out to have fever. So it's asthma becomes less likely, and that's why there's a red connection for speaks against this diagnosis. At some point, we really ask students to come up with a final diagnosis, and they get feedback whether they were right or wrong. I know it's a very simplistic approach, but this is where we currently are at. And they can try again if they didn't get the right diagnosis. And they can also give up if they think this case is too difficult for me. They can give up and get the diagnosis by the system. As a feedback, they can access the concept map created by the author and see how did the author develop this concept map with this virtual patient. In addition, we ask students to write a short summary statement, which is also kind of scored in a, we analyze the summary statement based on an assessment rubric from US colleagues, and we also can score that and give them feedback. So why do we think those virtual patients are helpful for clinical reasoning? You might be familiar with this triangle, and Steve already a couple of times mentioned the context, that context matters, and you might be aware of this triangle. So you have context factors that are related to the patient, like the patient presents, the gender the patient has, profession, migration background, disabilities, and so on. You also have the health professional or the team of health professionals. They can also be in a state like they are tired, they're stressed, they have some emotional problems, and so on. And they interact with each other in a setting, or you have encounter factors. So for example, it can be in an emergency room where there's a very stressful setting, or it could be in a private family practice where it's much more calmed down. So all these factors influence the clinical outcome. This is kind of how it's in the real world, but it's similar in the virtual world. So we, instead of the patient, we have the virtual patient. The health professional is, in our case, then the learner who takes on the role of the health professional. And the beauty of this is now that we have, around this, we have the learning environment. So we have the time of the day and the group where students work together on this virtual patient. So this is kind of I see it as a thing that surrounds this kind of contextual environment. And what we can do with virtual patients is we can somehow influence those factors, what you cannot do in reality, but we can do. We can decide the patient should be a lawyer or a salesman or whatever, and we can really play with those contextual factors. We can also influence the setting where the virtual encounter takes place, and to some extent we can also influence the learning environment. We can ask students to work in groups or work individually or work at a certain time of the day, so we can have some influence on that. So taking all these contextual factors into account, we started our project off with carefully designing our virtual patients. So we started with describing all our patient data. So we decided about their names, the age, gender, sexual orientation, profession, disabilities, migration background. So this was really the first step. We also decided about all the disease-related aspects. So which are the key symptoms the patients come to the scenario, what is the final diagnosis, and is it an acute or more chronic setting. We as well decided about the place of encounter, and in addition to that, we mapped it to our national competency frameworks to make it later on also more accessible for students. All this was an important step to guarantee that our collection is really diverse and that it's also a realistic patient population, that it has enough diversity to be realistic. What we ended up is a kind of huge Excel spreadsheet where all these virtual patients are described with those attributes. And then began the actual creation of virtual patients. So we divided them among our partners. It was more like a marketplace where we treated virtual patients against each other. We created then the virtual patient in English, as this is our common language, based on those attributes in the blueprint. We had 2 rounds of didactical review and revision of the virtual patient, content review by a content matter expert of another partner, then followed by a language and grammar check of the English version. And then this was followed by translating the version into all our partner languages. And the last step was that we publish it as an open access resource. So at the moment, we are having about 100 virtual patients completed. They are available online in all the partner languages. So coming back to clinical reasoning, I think there are a couple of factors that make such virtual patients useful for clinical reasoning training. So the first one I already mentioned, that you can vary and play with those contextual factors. The second one is that our cases are pretty short, so average time student need to complete one of those, including all the work on the concept map, is about 20 minutes. And it's a relatively large collection. I know you would need many, many more cases to make it really useful and more meaningful, but at least 200 is a starting point. So we think it can be one part of coming towards deliberate practice, as was already described by Steve. We always carefully paid attention that we have similar presentations of patients, but also very different ones. So I think it can also be a starting point for making students aware of comparing and contrasting similar cases, and tutors can also pick cases based on that and make students aware of similar or contrasting presentations. We explicitly do not have a focus on knowledge about diseases or disciplines. This is really focused on the decision making. There are many other resources which are much more helpful for really learning the background of diseases. And what we were also careful is about to use for the patient dialogue, to use layman language, so that students, when creating the summary statement, they have to really do a semantic transformation. And the last point, of course, is in the concept map, they have to do this prioritizing of findings. They have to develop the differentials, come up with the final diagnosis, state that they are confident. So this is all parts of the clinical reasoning process. I already mentioned as a second aim the integration into the curriculum, and this is, as we heard already in the morning, it's the crucial but most difficult part, and it's the same with this project. So a colleague from Poland already presented that yesterday, and this is also the work package that our Polish colleagues are leading. So we are developing a guideline, and in the hope that this will help educators integrate the virtual patients into their curriculum in a meaningful way. Because integration is still a challenge, and as we heard on earlier this day, it's not useful to have them as an add-on in the curriculum, but they need to be aligned with other teaching and learning activities. So for example, you could have them aligned with a seminar where then students bring their concept maps and discuss them with the tutor, for example. So they really need to be a core part of the curriculum. As part of this guideline, we are publishing practice examples, recommendations based on our experiences and our pilots we did with the virtual patients, and it's continuously updated until the end of the project next year. We also try to lower technical barriers for integration, so we try to make them as much or as easily accessible as possible, so students can use their university credentials to log in. We are providing learning analytics data for the educators, so we really try to make it as simple as possible. And we are also integrating VPs in virtual patients into different educational scenarios. So this is kind of part of the project. We are piloting them in different scenarios, and this is then something where we base our recommendations on, and we can see what works best and what maybe doesn't work that well. The last thing I wanted to talk about are our challenges we had in the project, but also in setting up the project. So one aspect was a little bit surprising, but we had many different physicians working with us together, and they were all naturally very focused on their specialty. But as our virtual patients are more focused on key symptoms, patients present with key symptoms, it turned out it feels unnatural for them to think a little bit differently on approaching virtual patients, as it's not a cardiology case, but it's a case about chest pain, and it's a little bit a different approach. So we had lots of discussions here. Also, of course, the pandemic has been a challenge. We started our project in spring last year. So we mainly met online, and it was also a challenge to have, the clinicians were not available. They were so busy in clinics, so it was really a huge challenge. But on the other hand, it was a booster of the project because, of course, online resources and especially virtual patients were highly needed at that time. Finally, I think all the challenges and the whole project led to very inspiring discussions we had with partners on, I call it, side aspects of the project. So if, for example, we had a long discussion on when we defined our migration background, what is it and how do we define it? And obviously there were differences how it was thought of in France than in Germany. So this was very interesting, and we learned a lot from each other. We also talked about many differences between countries. So for example, one topic was same-sex marriages, but it was also something more funny like different dishes. So we made the virtual patient scenarios realistic. So some patient came after having had a special Portuguese dinner, but we know that students in Germany wouldn't understand that. So it was kind of the local flavor to the cases, and that led to a discussion how we can make it still understandable to the different groups of students we have. So take-home message, I think that virtual patients are in many aspects suitable to train clinical reasoning and to support other methods we have to train clinical reasoning, so they can be one component of that. Integration remains a challenge, but we're working on that, and hopefully we can make them a core component of our curricula. And maybe the most important point, our international and also interprofessional collaboration helped us really to have a different view on all those context factors, because if you always think in your country-specific view, you forget that some things might be seen differently from your colleagues from another country. So this is really a major aspect of our project and was really fun to discover. So thanks very much. This is a picture of our team. And if you want more information, just go on our website and take a look. Thanks very much.
Thank you very much. And the question will be also about that international perspective. English became the lingua franca of modern medicine. Everyone learns medicine in English. Do you think it's really necessary that we have all the content translated to mother languages of our students? And if yes, why?
I can only speak to German medical schools, and I think it's, on the one hand, it's an opportunity to introduce English content and that they learn the terminology. As I said, for example, if they want to go to another country. On the other hand, if we are introducing virtual patients in the first semester of medical school, if they are they have new content, everything is new, and then it's already also in English. I think it might be too much. So I think it could develop that we start with German content, but gradually include also English content more and more. But I think in Germany, we are not that yet there that we can have everything in English. That's my impression.
Thank you very much. There will be more questions, but they are very general, and they will come in the panel discussion. So thank you very much.
Thank you.